knew exactly what you were asking me to do, I'd be happy to do it. So
we'll just jump right in after the intro.
Dr. Maxey, you're on mute, sir. There you go.
Good afternoon, everyone. Welcome to the Black Health Trust. We appreciate your attendance on this groundbreaking informational session that we feature credible health and medical information. Right to the program today, we're going to be speaking about the virus, going to be speaking about health disparities, and we want to answer any questions that you have about those. We have Dr. Daly Garnes with us from Houston, Texas, Dr. Ivan Walks, and also we have Dr. Barbara Neighbor-Stevens. We thank you so much. Dr. Stevens, you want to lead off with our first talk?
Thank you so much, Dr. Maxey, and good afternoon, everyone. I have been sitting at home, as many of us have been, observing what is being said and asked. And I am concerned that we are not necessarily hearing all the information that we need to hear and know as we address our own health. I want to address two topics today. The first is about monoclonal antibodies, and then I want to talk about what parents need to be aware of as they try to keep their children safe in the environment that we live. So the first one that we're going to talk about is monoclonal antibodies. What are monoclonal antibodies? Well, we have a short video to help explain exactly what this therapy is all about. Video, please. No audio.
COVID-19 monoclonal antibody therapy. Have you recently tested positive for COVID-19? Are you worried about your recovery because you were in a high-risk health group? To find out if you are in a high-risk health group, visit combatcovid.hhs.gov. If you are eligible, COVID-19 monoclonal antibody therapy can help you get on the road to recovery. When viruses or bacteria infect a person, the body responds by naturally making antibodies to fight them. This includes making antibodies to the coronavirus. Each antibody is specific to the intruder, so people have the ability to make billions of different types of antibodies. These are part of the body's adaptive immune system that helps defend it against recurring viruses and bacteria by learning to recognize and diffuse the intruder during future attacks. However, not all antibodies are equally effective in fighting the infection. While some antibodies can neutralize the intruding virus, not everyone is naturally capable of creating these good antibodies in a fast response time. Scientists have been hard at work identifying effective antibodies to fight the coronavirus. In the lab, scientists produce what is called a monoclonal antibody. The therapies act as a shortcut to help boost the immune system with good antibodies to help fight the coronavirus. They are for sick people with COVID-19. That's different from the vaccine, which is for people without COVID-19. The COVID-19 monoclonal antibody therapy is designed to mimic antibodies found to be highly effective in neutralizing the coronavirus. It's created in the lab, not from using other people's blood, and it's effective for outpatient treatments in one dose delivered intravenously, meaning through your veins. If treated with monoclonal antibodies, a person who tests positive for COVID-19 gets temporary enhanced immunity, which can help them avoid progressing to more severe symptoms. If you've been diagnosed with COVID-19 in the past 10 days and are in a high-risk group, ask your healthcare provider about monoclonal antibodies. Receiving this FDA-authorized therapy requires a one-time visit to a treatment center for an infusion. The treatment is generally well tolerated in patients. A COVID-19 monoclonal antibody therapy can turbocharge your road to recovery, putting you in the driver's seat. Visit combatcovid.hhs.gov.
Thank you so much. Now, I know that was a cartoon, but I think it gets across the critical information needed to appreciate what we have at our fingertips now to help prevent progression if we've been infected with COVID-19, to prevent progression to serious disease. Now, there were several things that were mentioned in that cartoon that we're going to revisit, such as how are you defined as a high-risk person and some other things. But next slide, please. I thought maybe we might want to start by just kind of reviewing. We've been talking about it and we've had several sessions on it, but what are the signs and symptoms of COVID? Now, the other thing that I want to share with our audience today is that the federal government in the last couple of weeks modified the emergency use authorization for monoclonal antibody treatments to include those who are positive with COVID-19 and who are exhibiting mild to moderate symptoms, but are at risk for developing more serious disease. In the past, the monoclonal antibody treatments have been primarily given in the hospital setting, and there were some more stringent criteria making you an appropriate candidate for this therapy. But this has changed, and it was put into magnificent action this week in the state of Mississippi. Those of you who are following what's going on may be aware that Mississippi experienced a total overwhelming of their hospital system, and they requested and received the deployment of the Federal Medical Services Group, and which is sort of like FEMA, except it's medical personnel. So they went down and they've established a field hospital outside the main medical center there at University of Mississippi. But interestingly, part of what they're going to be doing is taking care of patients. They set up a field hospital. But the other thing they're going to be doing is establishing a clinic, if you will, where people who have tested positive with COVID can come, and if they meet the criteria, be given the monoclonal antibody treatment with the thought that if they hadn't been vaccinated and were therefore victims of the virus, that perhaps serious disease could be averted if they geared up the distribution of monoclonal antibody therapy. This is also in its infancy steps in terms of operationalizing in Florida. So stay tuned to this. I have observed, as I do my day-to-day job, that I'm not seeing monoclonal antibody therapy being offered in the emergency room to people who present with mild to moderate symptoms. Now, I don't necessarily have access to all of the clinical information, but it has certainly been making me think that the public is not aware of this therapeutic option. So there are actually 3 products that are in this class, but only 2 have been authorized for this new approach in trying to manage the COVID surge. And Lord help me try to say these things. Casirivimab and sotrovimab. Now, whether or not I can say it and whether or not you can say it, don't worry about it. The point is, you need to be aware that these therapies are available. And if you get infected with COVID, you need to be able to advocate for yourself with the health professional that you encounter and ask, am I a candidate for this post-exposure treatment of COVID-19? Next slide, please. So who are the candidates for monoclonal antibody treatment? You need to be 12 years old or older. And if you are a child, you have to be at least 88 pounds or 40 kilograms. You have to have a positive COVID-19 test. You have to have mild to moderate symptoms. And these symptoms have to have appeared within the last 10 days. Outside that 10-day window, this treatment is not recommended. And then now the question is, are you at high risk of having more serious symptoms of COVID-19 and or having to go into the hospital? Next slide, please. So these are some of the more common high-risk factors that have been observed in patients with COVID-19. Let me emphasize they're not all, but some of the most common. We have talked before about how obesity and or overweight can increase your risk. Pregnancy can increase your risk for serious disease, chronic kidney disease, diabetes, immunosuppressive disease, or treatments that are immunosuppressive. So what are some of the immunosuppressive diseases? Well, if you have a lot of forms of cancer, you may very well be on some kind of immunosuppressive therapy. If you have had transplants, organ transplants, you are most likely going to be on medication that will suppress your immune response as a part of the management of the transplant. And there are other diseases such as the rheumatoid arthritis and lupus, the other rheumatoid type diseases that lead to immunosuppression. There are a number of heart or circulatory conditions that can put you at higher risk. And the mechanism is around the damage done to the lining of the vessels in the heart. Several of the chronic lung conditions can put you at higher risk, such as chronic obstructive pulmonary disease, severe asthma, interstitial lung disease, cystic fibrosis, and pulmonary hypertension. Sickle cell disease can put you at high risk, especially if you have reached a state in your disease where your spleen is no longer functioning. There has been the description now of significant risk associated in individuals who have neurodevelopmental disorders such as cerebral palsy. Not all, the mechanism of all of this is really not understood. A lot of this is not understood. And as we go on, things will change, and there will be conditions added and potentially conditions removed. Finally, if you have a medical device, in other words, if you have a tracheostomy or a breathing tube, and or you're on a vent, there are a number of individuals who have tracheostomy but are able to breathe on room air and do not require being on the vent. But in either case, with or without the vent, you're at a higher risk for serious disease, as is the case if you have a feeding tube that is inserted in your stomach. Next, please. Again, who are the candidates who should potentially receive monoclonal antibody treatment? Well, if you have one of those conditions and you're positive for COVID, you should talk to your healthcare provider. And if they feel that you meet the criteria, you should be referred to the appropriate infusion locations. And I want to emphasize, despite what you may hear, the federal government has purchased all of this therapy and it is available to anyone at no cost. Now, I will say though, depending on where you go to get it, there may be an administration fee that is charged, and most forms of insurance will cover that administration fee. But it is not, you do not have to worry about having to pay for this therapy. Next. How can I get the monoclonal antibodies? Well, first, you got to test positive for COVID-19 within the last 10 days. You need to talk with a healthcare provider. And this is where your personal advocacy plays into this. If you know you're positive within the last 10 days, you know that you've got mild to moderate symptoms and that you may have a condition that will put you at risk for developing serious disease or having to go into the hospital, you need to ask, am I a candidate for monoclonal antibody therapy? And then if that provider is not able to give you this treatment, you will need to advocate for yourself and locate an available infusion location. Next slide. Okay, now how can I find out where I can get my infusion? Well, this information has been derived from the Combat COVID HHS website, which has been at the bottom of most of the slides. You can contact them online or you can call them. And I verified yesterday afternoon that this number is working. So if you call this number, they will help you to identify where you can access this treatment where you live. You could
Can you
also
give that number out?
1-877-332-6585. Now, there are local sources that you probably can identify as well, like at your health department. But if all else fails, you can call this number. Next slide. I think this is the last one on the monoclonal antibody. Yeah. So at this point, we'd like to open up the chat to questions for Dr. Daly Garnes. And I would like to start it off by asking Dr. Daly Garnes, have you seen ready access in the community to this treatment outside of the hospital setting?
So I would say in my particular setting, and I'm in Houston, Texas, I cannot say that I've seen ready access. I've definitely encountered patients who were interested in getting the monoclonal antibody and that were potentially turned away from the place where they went. Or I feel like one thing that's happening is that people will contact their care provider, or they contact their provider, may not be familiar with their particular case. And that person may say like, okay, you just need to ride this out at home and, basically, take your Tylenol and rest. So I think that gets back to the important thing that Dr. Nabrit Stevens says is you need to know what are the conditions that put you at increased risk for having problems with COVID, and that would potentially qualify you for getting monoclonal antibody therapy. So when you contact someone about trying to get monoclonal antibody therapy, you can say, I know that this is available. You may not have it, but can you tell me who does? And I think I qualify for these reasons. it really is important that you advocate for yourself.
Let me ask a question. How does monoclonal work with having had the vaccine or not having had the vaccine?
So in terms of if you've already been vaccinated and then you get COVID, which we now know can happen, there is no effect. Like, you can still get the monoclonal antibody if you meet the criteria. So if you are at risk for getting severe COVID disease, and you are at least mildly symptomatic, you can still get the monoclonal antibody. Now, on the other end, if you have COVID, you have not been vaccinated, and you get the monoclonal antibody, the recommendation is to wait for 90 days after you've gotten the monoclonal antibody before you start getting the vaccine.
And we did not really go into depth because I wanted it to be a live conversation. Can you, excuse me, discuss the mild side effects that have been reported with monoclonal antibody therapy?
So for the most part, they are mild. Headache, nausea, vomiting are some of the things that are most commonly mentioned. There have been, I know very early on, there were some reports of people having low blood pressure associated with the monoclonal antibody, and even some allergic reactions. Again, anybody can have an allergic reaction to anything. But for the most part, the patients that I have seen that have gotten the monoclonal antibody have tolerated it very well. For those reasons, initially when it was first released, we had to watch patients in the hospital for at least an hour after they got it. As more and more people have received it, that period of time that you need to watch people has been decreased. And I think that's also changed it to, you don't always have to get it intravenously. You can even get it as a subcutaneous shot, which they've done to really facilitate it being given out in the community, because we really are trying to prevent people from having to come into the hospital.
So this is Dr. Walks. I have one of those practical questions. So if I test positive for COVID-19 and now I'm symptomatic, so I know that I have COVID-19 and I know that I can probably spread COVID-19. Now I'm moving around trying to get to my doctor's office with my COVID, and then I'm trying to get to the place to get the monoclonal antibodies with my COVID. So can you just talk through what's a person supposed to do when everybody is saying, you get your COVID away from me, you know you're sick, why aren't you at home? How do we deal with those kinds of things?
So this is a really good question. And I think it's really going to depend on where you are and what your situation is. But in most cases, the care providers that are going to help you make the decision whether you qualify for the monoclonal antibody, that's a conversation that you're likely going to have either by the phone or virtually, so that you're not having to come into direct contact with people. Now, the places where they're giving the monoclonal antibody, for the most part, they're giving the monoclonal antibody to people who have COVID, because it is only recently that we are now able to give it to people who don't, which we can talk about. But so they're prepared, they should have everything set up, have people in isolation, have the people who are providing the treatment with appropriate personal protective equipment. So they are aware and they are set up to do that. In the meantime, a lot of this is going to need to be done by contacting people. So either online, by telephone, or virtually.
Thank you.
That's excellent. So I had this question before. I know Dr. Neighbors-Stevens said that the weight limit is 88 pounds. The age limit is 12. And these are the conditions of the emergency use permit to use that. But are there any people doing off-label use of this in a perceived emergency of, say, an 8-year-old child who weighs 65 pounds?
So one of the issues is with this emergency use authorization, it's different than when you have something that's actually approved. And so if you use it outside of the emergency use authorization, it has the force of law. So that's one of the issues I know that has come up in our facility, is that, there are situations where we feel like patients could benefit from the monoclonal antibody, but we are not able to give it to them because they don't meet the criteria within the emergency use authorization. So it is helpful that the EUA has been expanded, but there are still patients who do not meet that. And, at least in our facility, we still have access to convalescent plasma. And so a lot of times we're using convalescent plasma in those cases where we would like to use the monoclonal antibody, but our hands are tied because of the EUA.
Can you define convalescent plasma? And by the way, but first, please introduce yourself, doctor.
So I'm Janine Daly-Garns. I'm an infectious diseases practitioner for both adults and children in Houston, Texas, in the Texas Medical Center. And so what is convalescent plasma? So basically, it is a collection of antibodies that has been taken from people who have had infection with COVID. And they actually pulled antibodies from those people because they have an enriched number of antibodies. So as opposed to the monoclonal antibody, which the cartoon showed us is made in the lab, these are natural antibodies. So it's not just one type of antibody, it's a bunch of antibodies that were developed, that people developed in response to the infection that were then collected and then can be administered to people who have active infection.
Thank you. Are there any other questions in the chat before we continue?
No, there are no other questions in the chat. I think everything that was in the chat, the questions about asthma, we covered. But of course, if anybody thinks of something else before we end, we'll certainly circle back and try to address that.
Yeah, I think you have some more slides.
I would just like to comment that Dr. Daly-Garns has been answering the questions in the chat while she's been, I don't know how she does that, but that whole multitasking thing is pretty impressive, doctor.
Okay, so she can probably text with no hands, right? Dr. Neighbor, do you have further slides?
I'm not that.
Yes. Yes, the next topic that I wanted to address is that regarding what parents need to be aware of and think about as we progress into face-to-face school participation with or without mask, with or without vaccine access for children under 12. This is, to me, probably one of the most difficult situations most parents will have to contend with for the next several years, because we know for a fact that there are over 90% of this country is in the red zone as it relates to the amount of infection in the community. And we know, those of us who've been attending these sessions regularly, that as the community viral load increases, so does the infection rate. With the kicker now that we're dealing for the overwhelming majority of the cases being Delta variant that has an enhanced ability to infect, we basically are sending our unvaccinated children, and remember, children under the age of 12 can't be vaccinated, and children over 12 that have not been vaccinated because of their parental decision-making. We're sending these children into an environment where there is plenty of virus floating around, and there is a huge potential for infection to occur for both adults and children. Let me also quickly say that one of the biggest sources of infection for children who are too young to be, well, for children who are not vaccinated, is unvaccinated adults. So we have an untenable situation in the way that I think as a pediatrician of putting our children in harm's way. So given what we have to contend with now, what can we do to make the best out of a potentially very dangerous situation? So that's what the next few slides are going to be about, and hopefully will generate some additional questions. Next slide, please. Now, as we talk about COVID and the symptoms that you might see in children, and I thought we might want to review that, lest there be anybody who thinks that COVID is not something to worry about with children. You know, usually we report CDC statistics, but the American Academy of Pediatrics and the Children's Hospital Association have been maintaining a state-level database since last year, which has really been one of the strongest reservoirs of pediatric information. They reported last week that as of the week ending August 5th, 15% of all newly reported cases of COVID-19 in this country were in children. This translates into a rate of 129 cases per 100,000 children. So unlike last year, when the kids were at home, we were all sheltering in place, we weren't dealing with Delta variant, we are seeing an explosion of COVID cases in children. In that same week ending August 5th, there were 94,000 cases of COVID in children, which represented a 31% increase over the previous week when there were 72,000 cases. And the week before that, there were 39,000 cases. So since July, we have seen a tremendous increase in COVID in children. Now, let me remind you, schools just started opening week before last, and they will be slowly increasing in their opening after Labor Day, which is when the majority of them open. So we're seeing the surge before we even get them into the classroom. And there's some early reports coming out of Florida where they have opened, where they've already had to quarantine over 100 kids after exposure. The good news, and I put air quotes around this, the good news is that even with, up till now, even with this load, it's been only about 2% of the kids requiring hospitalization. And depending on where you look at the data, by that I mean, depending on which state you're looking at, the deaths are occurring in a range between 0% and 0.03%. I pray that it continues at that rate. I cannot say that we can bank on that. So having said that, let's talk about the symptoms. So what we know about when there are symptoms, and so often there are no symptoms, the infection is going to occur and the symptoms are going to begin somewhere between 2 and 14 days post-exposure to a positive COVID person. But I can't overemphasize enough. You can't rely just on symptoms to let you know that your child may have been exposed and infected. Because many of them, probably the majority of them, are not going to have much in the way of symptoms. But they can have really severe symptoms. That's why you're hearing about all of the pediatric hospitals being overwhelmed in their ICUs and all the ventilators taken up, because we're now seeing some very significant disease. Next slide, please. This slide lists some of the common symptoms that you see in both children and adults when they have COVID-19 infections. Again, let me emphasize, you can be asymptomatic and totally infected. So you may have fever and chills, cough, shortness of breath, difficulty breathing, an overwhelming fatigue, a feeling of tiredness, body aches, headache, a new loss of taste or smell. And this has I've seen statistics of over 60% of the loss of smell and taste as an early sign of infection, even if you don't have many other symptoms. Sore throat, runny nose or congestion, nausea or vomiting, and diarrhea. As I said before, these are some of the most common symptoms. By no means are they the only symptoms. If your child is complaining of something different, I used to say to parents all the time when they would call me or come in and say, my child is sick. If I did my evaluation and I didn't come up with something, I would always say to the mother, I'm not saying that there's nothing wrong with your child. You know your child better than I do, and you see something that's not normal for your child. We just haven't identified the cause of it yet. So don't think just because I say I'm not finding anything that I don't believe that there might not be something wrong with your child. If you think something is not right about your child, don't hesitate to reach out to your health professional. Next slide, please. If some of these symptoms are what you're dealing with, you get to emergency care right away. Trouble breathing, where the child or the adult tells you, I can't get my breath. Persistent pain or pressure in the chest, something just not right in the chest. New confusion. Now, your child is not normally confused. So all of a sudden they seem to not know where they are, or confused about what day it is, or trying to drink out of drink out of a pot instead of a glass. That would be new confusion. An inability to stay awake or to wake up. It's a really urgent indication for seeking emergency care. And if their color's not right, now this one is a tricky one because we have the rainbow in skin tones. If they are looking pale, or if they're looking dusky blue or kind of a gray aura around either their lips or their nail beds, or just they're, looking at them in the face, they just don't look like the right color, that's an urgent issue that needs to be addressed right away. Next. So when should you get tested? This is an interesting question. This answer, for those of you who have been following along since early last year, this answer has been evolving. So at the moment, if your child is demonstrating symptoms, you need to get them tested. If they have had if your child is unvaccinated and they have had close contact with someone who is COVID-19 positive, need to get them tested. Now, there is a guidance out from CDC that I want parents to be aware of, because I want you to not forget our maxim, which is use common sense. So for kids in the K through 12 indoor setting, they have modified the definition of close contact. And they're saying now that if your child was within 3 to 6 feet of an infected student or potentially infected student, and the infected student and your child were both wearing masks correctly and consistently the whole time they were in contact with each other in the classroom, they are saying that may not need to be followed up with a test. So I'm giving you what CDC has stated, but I want you to understand what this means, given the times we're in. Whether or not the other student that was positive had that mask on, or that there were other children in that room who were positive and just haven't been identified yet and didn't have a mask on. I would encourage you to take to investigate and take the action that is most appropriate for the information that you determined that went down in that classroom. Next slide. So what do you do if your child has COVID? Well, first, not only your child, but any person in your family. If they have COVID, monitor them closely. You want to stay in touch with your health professional. If there's anything going on that you question, reach out. As long as it's not one of those emergency signs or symptoms that we just talked about. In that case, you want to get to an emergency facility. Now, this is something people haven't probably thought about, but once your child recovers from COVID, they need to have a follow-up visit, either face-to-face or through telemedicine with their doctor before engaging in physical activities. And the reason for that is, even in cases of COVID-19 where there are no symptoms at all, or where there are significant symptoms, there can be damage done to different organ systems which need to be identified before the kids resume their normal running around and sports activities and all of that. So do follow up after they have finished their time of being sick and in quarantine. Next slide, please. Now, one of the things that could be going on in a child who has had COVID, even if they didn't have symptoms, is something called multi-system inflammatory syndrome, or MIS-C. This syndrome also occurs in adults. So far, it has been very rare. However, there are some interesting facts that you want to be aware of. First of all, what it is it's an inflammation occurring in different parts of the body, either the heart, lungs, kidney, brain, skin, eyes, or gastrointestinal organs, or inside the stomach, either the stomach itself or the guts. Now, as of July 30th, CDC says there have been, this is cumulative since the beginning of the pandemic, 4,404 cases of MIS-C, with 37 deaths occurring in children. 29% of the cases of these 4,404 occurred in Black children. 34% of these cases occurred in Hispanic or Latino children. 60% of the cases occurred in males, and 99% of the cases occurred in a child that had been positive for COVID-19, and that 1% that hadn't had a positive COVID test had had contact with someone who had a positive COVID-19 test. So my message to you is, it's rare, it happens. The more kids who get COVID-19 infections, I guarantee you the more cases we're going to see. It typically occurs about a month after they have had their acute COVID-19 infection. Next slide, please. What are the symptoms that you might be observing? That gut pain that I told you about, bloodshot eyes, tightness in or pain in the chest. They may even say, "Mommy, my heart hurts." Diarrhea, feeling extra tired, headache, low blood pressure, neck pain, rash, and vomiting. If this is going on after they've gotten over that acute infection, you need to reach out. Next slide, please. You want to seek emergency care if they're having trouble breathing, if that pain or pressure in the chest is increasing, that new confusion, that inability to wake or stay awake, or change in color. Same, if that sounds familiar, we just went over this earlier. If any of this is going on, seek emergency care immediately. Next. Another condition that is becoming identified in children is long haul COVID-19 syndrome. As you know, we had our first international symposium on this back in June, but there really hasn't been much information on this regarding children. It's just now beginning to come out. And again, as time goes on and we have more and more children infected with COVID-19, we will start having more information available about this condition. But again, what it is a physical or mental symptom lasting 4 or more weeks after they've gotten over that acute infection of COVID-19. There's not a lot of information. United Kingdom Office of National Statistics is reporting when they reviewed their information, 13% of 2 to 11-year-olds and 14.5% of 12 to 16-year-olds had symptoms after 5 weeks. Now, that's not to say that they had the full-blown long-haul COVID-19, but that lets us know that kids can go on to develop post-acute COVID-19 conditions. And so just because they've gotten over the acute infection doesn't mean that you don't need to still keep an eye on them. Keep that in the back of your mind. Next slide, please. And what are some of the long-haul COVID-19 symptoms? Fatigue, difficulty thinking or concentrating, also described as brain fog, cough, trouble breathing, joint or muscle pain, chest pain, and significantly depression or anxiety. And I should say that depression and anxiety is working its way up on the list of things that are being seen in children, even in the acute phase. Headache, fever, unusual rapid heartbeats or heart palpitations, loss of smell or taste, and lightheadedness when standing up. And there's a lot of interest in that symptom because it's thought to be tied in with there is concern that this may actually be tied in with some neurological issues. Next slide. Okay, so that's the end of the slides regarding children. So let's talk about some questions that parents might be having going into the school year. Dr. Garnes, have you actually had any pediatric cases in the ICU there in Houston?
So personally, no, but there have definitely been a lot of cases in the ICU here in Houston. In fact, one of our probably the largest children's hospital in Texas actually had to ship fly one of their patients to another city in Texas because their ICU was full. So we've definitely had a lot of severe cases here, which is very different than how things were a year ago. Before, when we were hearing about COVID and before it really got started here, there was a lot of discussion about like, oh, are we going to get overwhelmed? And then it was like, the adult ICUs all got overwhelmed. And really what ended up happening was that the pediatric critical care folks got pulled over to help take care of the adult patients. And so now this is the first time that we're starting to see the pediatric critical care get overwhelmed.
I don't see any questions in the chat. If anybody has any questions that come to mind as we go on in the program, we will certainly be happy to circle back and try to address them. And I'll turn it back over.
I have one thing I wanted to bring up. Related to our previous topic, when we were discussing the monoclonal antibodies, I mentioned the monoclonal antibodies were now authorized for prevention, but we didn't really go into that in more detail. And so really what I just want to say, so number one, to emphasize that the monoclonal antibody is not a substitute for getting vaccinated. The people who qualify for getting the monoclonal antibody, this is not something you get without having been exposed to COVID just in case. It is only in the case that you have a known exposure to COVID, or you're in a situation where your likelihood of being exposed is really high, such as someone who's in a nursing home or someone who is in a correctional facility where there's an outbreak going on. And then in those cases, it is for people who either are not eligible to be vaccinated, or people who are partially vaccinated, or people in whom the vaccination is likely not going to work as well. So for example, immunocompromised patients, people who, especially people who are getting things that work against their B cells. So people who have cancer, who are getting medications like rituximab, people who have rheumatologic conditions, who may also get similar medications. Again, the transplant population. So those are the people that the monoclonal antibody is really recommended for prevention.
Ivan, you had a question?
I do, because I'm going back. First of all, thank you for that level of clarity, Dr. Daly Garnes. I think it's very helpful. My question goes back to a slide about the children who may not need to be tested because the child who has COVID had a proper fitting mask and the other child had a proper fitting mask and they were wearing them properly the entire time. My response to that is, really? There's someone who is reviewing a videotape to make sure that the kids had their masks properly fitted the entire time they were in school? And is there some course that parents take to make sure that they get their child a mask that's fitted? I see a lot of cute masks on kids. The ones that come 5 in a cellophane package at your local dollar store, they look really cute. And I think a lot of times, I've had these glasses since I was about 6 years old. And if I don't have a mask with the little metal thing that seals, my glasses fog up. And so I think there's a lot to be taken for granted when you say, if the child's mask is fitted and the other child's mask is fitted and they wore them the whole time. My only response is, come on. So just please comment to my, come on, really?
Yeah, that sounds like common sense we need to use, right?
Which I think is a point Dr. Nabert Stevens was making. I would add to that is, also being aware of, what age children are we talking about? But, especially since in a lot of cases, wearing the mask or not is optional. And we know that unless we've got, both parties wearing a mask, like we're not getting our optimal protection. So, I think at the end of the day, it's probably going to behoove you that if you were notified that your patient was in the classroom, to get your child tested. I think one of the questions is, if the schools are getting that information, who are they going to feel like they need to notify? And I think that's a question that we as parents need to be aware of, like what the school's policy is going to be regarding notification.
Let me speak on that a minute. I have a concern, and sometimes I don't believe that people should lie in normal life, but I do believe that occasionally if you have a concern about a child's medical condition or yours, you might need to adopt a little bit of Hollywood and make sure that your child gets attention or you get attention. The guidelines are in a legal sense and they're broad because they fit a whole category of people. But if you think your child needs attention, the last thing I'm going to worry about is what the so-called rules are. You're going to advocate for your child. Let me, Simon, I have a few slides I want to just show Dr. Garnes and Dr. Nabert. And by the way, Dr. Nabert Stevens, that was an excellent, excellent presentation. Thank you so much for that. Simon, I have a few slides I want to speak about why Dr. Daly Garnes is on, and other doctors are on. I had a disturbing situation yesterday where I got sent a video by some supposed acquaintances of mine. And on this video, it showed a guy who purported to be a pathologist, who had also taken some courses in immunology. And he was telling people that they should not be interested in the vaccine. And I couldn't believe this guy, who was normally respectable. I just wanted to go back to a few basic concepts. If you can show those slides, Simon. Kenny, are you there? Can you put them on? Looks like we're having a little technical problem. Well, I want to talk just a minute about the mRNA virus, that when it's given, usually in the deltoid muscle, is taken up by certain cells called dendritic cells. And this stimulates both cellular as well as humoral immunity. That is via the T cells and B cells. So messenger RNA is a genetic material that tells your body how to make protein. There are slides that I sent that say Maxi slides. Is Simon on? Okay. So the mRNA vaccines, there you go. Can you expand that to the whole screen? So these mRNA cells is taken up by certain cells. They're called dendritic cells. These present these to the body, and both cellular as well as humoral immunity. This is via T cells and B cells. The messenger RNA is a genetic material that tells your body how to make proteins. I reviewed some of this on the cdc.gov site, so this is readily available. The vaccine is made of mRNA that's wrapped in a coating of lipid, which is essentially a fat that makes delivery easy and keeps the body from damaging that mRNA while it gets to do its job. The mRNA vaccine teaches your cells how to make copies of the spike protein. So what they've done is manufacture by something called recombination an artificial spike. There is no virus in this vaccine, okay? If you're exposed to the real virus later, your body will already have instructions of how to fight it. Next slide. Next slide. So the vaccine is made up of the RNA. Go to the next slide for me. So this vaccine does not contain any virus. I can't emphasize that more. When the body receives this vaccine, it can sometimes cause a mild fever, just like you have COVID. That's normal. Some people get chills, some people get headaches. It's been shown that older people may have a less reaction. Younger people with stronger immune systems may have a more violent reaction than others. In my family, at my age, I had no reaction. My youngest son got sick for a day, but this is normal, and it does show you that the virus is working. The other question that came up, after the mRNA delivers its instructions, your cells break it down and get rid of it. For example, we know that with the Pfizer vaccine, if you don't keep it at minus 70 degrees, it destroys it. If you don't keep Moderna at a certain temperature, it destroys it. So in the body at a temp of 98.6, there's limited survivability, plus there are a number of entities that can destroy this vaccine after a short period where it instructs the body of what to do. Next slide. Again, there is no virus in this at all. None whatsoever. I want to go for questions because I've heard people say that the virus stays in the body, it migrates to the brain, migrates to the muscles. It does not. So I'm hoping there are some questions in the chat that we can address, if there are any. This is like a 3D copier where you can print a chair, you can print a pot, you can print a vaccine, but we're printing now something that looks like the spike protein. And that print is so real to the body, it generates an antigen action that produces an antibody from the body. And once that recognition is in the body as an antibody base, when you get the real virus, it can fight it. That's as simplistic as I can explain it. Of course, I've downgraded that number, but it's quite interesting how they can do gene splicing and all of this. That's above what we want to talk about on this call. Are there any
So
questions?
Dr. Maxey, I don't see a question in the chat. I just wanted to clarify or maybe add something. Of all of the hundreds of millions of doses of vaccine that have been given in the US and worldwide, I don't know of any case where somebody has gotten the virus from the vaccine, which makes your point. Hundreds of millions of doses and no case where someone has gotten the virus from the vaccine. I just wanted to make that very clear.
That is absolutely true. There's another caution I want to put up. We say that the vaccine has a 95+% efficacy. Let's turn that around. That means there's a 5% number of people that it's not going to work in.
Mhm.
So I'm presuming that our population in the US is somewhere around 400 million. We'll use that. So for 95% of those 400 million, it's going to be effective. I don't know what 5% of 400 million is, but there's a lot of people that it may not be effective in or partially effective in. And we also know that over time, these two vaccines that are mRNA vaccines, both Moderna and Pfizer, there may be some decay of effectiveness over a period of time. We don't know that for sure, but in a recent study I read about a head-to-head study, it seems that the Moderna vaccine was more effective for longer against the variants, even though the Pfizer still remained somewhat effective. So there probably will be a booster vaccine given in the near future. And I've advised patients and had them receive vaccine boosters over the past few days, whether they had asthma, chronic kidney disease. And maybe we can ask Dr. Janine and Dr. Neighbor Stevens and you and myself some questions around that. And what about these vaccines in terms of getting boosters, in terms of long-term effectiveness? And I'd like to discuss some of that. Dr. Garnes?
I think, because that's the other big news item that came out recently is that the FDA is now authorizing a third dose of vaccine for certain people. So right now, that authorization is limited to people who are immunocompromised. So probably the data that's been out the longest is specifically people who have had organ transplants. And so they're authorizing it for that population or for people who are similarly immunocompromised. So again, I take you back to people who have cancer. So the cancer itself, if you have something like leukemia, for example, can compromise your immune system itself. And then depending on other types of cancer, or even for leukemia, depending on what kind of treatment you're getting, the treatment can cause you to be immunocompromised. Other types like stem cell transplant, depending on how things are going with your stem cell transplant, you can be considered adequately immunocompromised. And then also for persons, again, which is really common in our community, with rheumatologic diseases like rheumatoid arthritis and lupus, would also probably meet that criteria for being adequately immunocompromised. With regard to how long the immunity lasts from the vaccine. So again, we're still learning about this. One, it seems that the immunity from the vaccine lasts longer than the immunity you get from the infection itself. That's one point that I want to make. But we don't know how long the immunity from the vaccine works. And the other thing that I just put out there is that right now we're basing our immunity on whether we can detect antibody. And detecting antibody in somebody's blood doesn't tell the whole story about whether they're protected against infection. Because as Dr. Maxey mentioned, we also have our T cells. There are other parts of our immune system that also protect us from infection. But the antibodies are the easiest way to measure. So, in terms of whether everybody's going to need a booster, I think a lot of people feel like eventually that's likely to be the case. We're not sure when that's going to be, if it's going to be a year after you got your vaccine, or if it's going to be several years after you got your vaccine. We're still waiting to figure out that information. But those are, kind of the questions that we're dealing with right now.
Excellent. I notice I have a question too. I'm going to ask it of a noted OBGYN physician who's on the line, just so she can get a heads up. I'm about to be a grandfather in a few months. And so I'm concerned about vaccines in pregnancy. And is Dr. Villanueva available to speak to some of the recommendations on that? She's the president of the National Medical Association. Can you make sure she's unmuted?
She's still muted.
I think she might have stepped away.
She put in the chat that she is on a train and can't speak right now, and put that she's sorry that she's on a train and can't speak.
Okay, very good. The recommendations, though, that I have seen is that the risk of having an untoward reaction are worse than the benefits of taking the vaccine when you're pregnant. It seems that pregnant women have more hospital admissions, have more difficulty. Dr. Garnes, do you agree with that?
I do. There's actually was just having this conversation with my gynecologist a couple of days ago that, we know that pregnant women who get infected with COVID are at increased risk for having severe disease. They're at increased risk for getting severely ill, for ending up on a ventilator. And there have been pregnant women who have delivered their babies and have not been there to see them. We know that that can happen with the infection. And we are not seeing poor outcomes in pregnant women who are vaccinated. And so the recommendation from the American College of Obstetrics and Gynecology has been to vaccinate pregnant women for quite some time. But that recommendation is now being made by other organizations as well. So it really, the risk to benefit really is in the favor of getting vaccinated if you are pregnant or planning to become pregnant.
And let me just add to that, Dr. Maxey, when you ask a question, people go to great lengths to answer. So Dr. Villanueva, who is on a train and can't speak, but is still listening to the show, did put in the chat that all pregnant and nursing women should be vaccinated.
Excellent, excellent, excellent. And I want to amplify that just a minute with our favorite pediatrician, Dr. Neighbor Stevens, as well as Dr. Dale Garnes. For nursing mothers, how does that affect the infant in a positive way or any other way, receiving the vaccine as well as the fetus? Does that vaccine go through to that fetus? Does it provide any protection at all?
Well, the vaccine is not going to go through, but the antibodies potentially that the mother produces can be transferred to the baby, to the fetus, as well as to the baby once it's born, if she is breastfeeding, which, as you know, is something that we advocate very strongly, that breastfeeding is best. So yes, we do see that there is great benefit for the pregnant woman to be vaccinated and the nursing mother to be vaccinated.
Excellent. Dr. Walks, are there any psychological, psychiatric effects that we see? I won't ask that question. But I'm concerned that we still have people that are having difficulty and hesitancy moving forward with this vaccine. And I've struggled with this, and we know we don't want to shame people, and we don't want to be angry with them, but we do want to try our best to do the best of our ability to show them logic, credibility as to why they should take the vaccine, and certainly not discourage anybody else about it. I'm wondering if there are any other approaches that people have found beneficial to helping with the vaccine, or any lay questions. I know we have a number of individuals that have been with us a while. I'd invite comment, and I'm going to ask a certain ER doctor who's in New Hampshire to make a comment of what he's seen with people. Dr. Steiner?
While we're getting Dr.
Yeah,
Steiner
okay,
unmuted,
here I am. Yep.
Oh, Dr. Steiner?
Yes.
Oh, go ahead. You're ready.
Yeah.
Go ahead.
I passed over to Dr. Maxey and to Dr. Stevens during the week a little video of a physician encouraging people not to get the vaccine. And we're seeing a lot of misinformation on the web. And this raises the question, how do we approach these people? How do we give them the confidence that there are places they can go to believe the truth? And they're believing people at the fringes that have either they do have degrees, and for whatever reason, they're not in the mainstream of science. And so this presents a problem, I think, for all of us, and even people watching. Who is the authority? Who do we believe and who do we trust? And I think we have to somehow reach these people in a way that reaches them in their language and in their speak. And this is the challenge that I've been having. Unfortunately, it's turning into also a political wall where unfortunately many Republicans gathered together to celebrate that vaccinations are not going as well as maybe Biden had hoped they would. I think there are many forces here. I think a lot of it we have to acknowledge is political. I think there are financial forces as well. And this is a great burden. And how do we get to these people? I think we have presentations like the Black Health Trust has, that if you can't believe the folks here, who are you believing? But when I send people of all different colors to the Black Health Trust, they come back to me and they'll say, well, this one only has a PhD, or this one really isn't a specialist in the disease, or they'll find some sort of criticism that lets them believe what they want to believe. So at the end of the day, I don't know how to reach these people. Maybe there are folks here that have had success that they can share.
Thank you so much.
Sorry. I think the one thing I would say, Dr. Steiner, is, and I think a lot of pediatricians, because, we've been dealing with vaccine hesitancy in general for a long time, is that to remember that there's a spectrum of vaccine hesitancy. And, when you're dealing with, people that are on that spectrum, it's helpful to assess where they are on that spectrum. So, at one end, you have people that are, fully believers in vaccines and, they're going to take it. And on the other end, you have people that no matter what information you're going to present to them, they're fixed in their belief and you're not going to be able to persuade them. But the vast majority of people that you encounter are going to fall somewhere between those two. And I think the big thing is just assessing where people are and having the conversation with them where they are. And I think that's why it's particularly important when you have a relationship with someone personally, to give them your information, your opinion on what are credible sources, and ask them what their questions are, be willing to answer their questions in a non-judgmental way. And, ultimately they have to make the decision for themselves, but we just want to make sure they have the best information possible.
Let me just add to that. Oh, go ahead, Dr. Neighbor-Stephens. You can add to that, then I can add to that.
Okay, dokie. So I can't remember who it was who made this statement, but I heard this and I think it's just such a pearl, that science is not truth. Science is the pursuit of truth. And for some reason, many people seem to not be able to identify or accept the fact that new information becomes available and therefore previous information is no longer accurate. And because what you said 2 months ago is no longer true, that seems to somehow or another violate your ability to be truthful. And that is not the fact. So I don't know when we got to that point, but we need to help everybody understand that, especially with COVID, we don't know. There is so much more we don't know than what we do know. And as time goes on and our experience is prolonged with this condition, we will learn more things. And that will change some things that we thought and said previously. That's the way it goes.
So let me add to that. First of all, I think it's really important, all of the things that have been said about this. There are two ways that I look at folks who have not yet been vaccinated, and I completely agree. Telling people negative things about themselves and about their attitude is certainly not helpful. At the same time, we can tell them positive things about the use of the vaccine, the hundreds of millions of doses that have been, all of that we can tell them because we're giving them information that maybe they don't have. I think to Dr. Steiner's point, we can ask them to look at what the motivations are of people who are giving them information. The last time I checked, unless Dr. Maxey's holding out, nobody on the Black Health Trust is getting paid. And so we don't have that same kind of incentive to go in a very different direction. We understand that when people are not vaccinated, they can carry the virus around. And yes, vaccinated folks can too, but Dr. Maxey covered the percents, right? We have to be willing to say to family members, no, you shouldn't go see grandma when you're unvaccinated and you're not wearing a mask. No, you can't come over to the house when you're unvaccinated and you don't wear a mask and you've just gone to whatever palooza it is with 20,000 of your closest friends in an enclosed stadium. We have to be willing to, I know at our church, when we reopen, we're reopening for people that are fully vaccinated and willing to wear a mask and willing to wear a mask properly. So I think it's just one of those things that we have to judge our own willingness to control the exposures that we can in the environments that we can control those exposures while not telling other people negative things, but helping them with good information.
Let me comment too, Dr. Walks. I had a conversation with one of our advisory board members earlier. And he suggested that we cordially invite callers on this particular call to join the Black Health Trust. And we clearly try to give good medical, good healthcare information to the best of our ability. But we also clearly invite our community to support us with advice, with input. We'd like to be able to have your comments, your letters, to help us better structure our program to reach more people. So we'd like you to, the invitation that you got has an email on it. Yakini, can you give that email? Well, she'll come on in a minute and give that email. But love you to join us. But let me go further. I think there are several classes of people who give this misinformation. My biggest concern is I believe there are certain people who purposefully intend to provoke harm among communities of color. And I want to declare war against those people, none of which are on this call, but there are people who believe that if they kill enough of certain populations, they'll be able to politically and financially win the day. And they're willing to risk their own lives, their own populations in order to do that. And we have to guard against that. That's why we came up with the word use common sense. I don't care what people say, if it doesn't sound right, if it sounds like it's going to hurt you or your kids, do what your heart and soul tell you are right. Then there are those who are confused about the information being given, and they seek sources of the internet, the dark web, rumor, gossip, etc. But they are innocently giving bad information. And I notice most of the physicians who give bad information are usually not clinicians. Most of them are subspecialties that have no direct patient care experience. And I definitely believe that those people need some source of correction. To be sure, there are well-meaning people even among our ranks who have the wrong information. We seek to debate with them on our clinical meetings of our medical advisory on Wednesday nights, once or twice a month, and we'll continue that. We don't want to shut anybody down because we don't know everything, but we know what science and common sense tells us. And then there are those who are just afraid. So we can mostly address those who are afraid by giving them facts. We can spoon feed them, help them get this, and believe that all the millions of people that have been vaccinated, we have seen the disease go down, so we know it works. Are there side effects? Are there potential problems? Yes, but they don't outweigh the potential benefits. So I'm concerned that we have the right approach. I appreciate our speakers, Dr. Daly Garnes. I really appreciate our co-moderator, Dr. Neighbor Stevens. And I appreciate Dr. Walks, our resident psychiatrist who takes care of me. And I'll take my Thorazine this week, Doctor. And I appreciate our advisory board, our virtual assistant, our producers. And I'd like to ask our co-moderators and guest speaker if we have any further or final comments, or if there's anything in the chat that we need to address. Dr. Garnes?
I think the biggest take home is just to do what you can to keep yourself safe. Make sure that you're here so you're getting good information. And, we don't have control over what the people around us are doing, but we have control over what we're doing for ourselves. So, take what you can and do what you can. Wear your mask, get vaccinated if you are able, keep your distance, use your common sense, and do what you need to do to keep you and your family safe.
Thank you. Dr. Walks?
First of all, I want to add my thanks for all of the good information that we've gotten today. I want to hit on one point that I don't think we've touched on as yet today, and that is this notion that the decision to get vaccinated, the decision to wear a mask, that all of these things are a personal choice, and everyone has a personal choice. Let me just say that it's not only a personal choice. It's a personal choice that has consequences for all of the people around you, and by extension, all of us. So when people say that, well, it's a personal choice, it's really not. It's an opportunity for the current variant and other variants to spread when you decide not to get vaccinated. It's a personal choice to put members of your family who may be immunocompromised. Dr. Daly Garnes, Dr. David Stevens has given us a lot of information about how folks maybe can't get vaccinated for one reason or another. Young children that can't get vaccinated. So this notion that it's a personal choice just doesn't stand up against all of that. So I wanted to make that particular point, that your personal choice really impacts a lot of other people.
Thank you, Dr. Walks. Dr. David Stevens?
I want to urge everyone to stay vigilant. There is new information, new situations developing every day. We cannot afford to say, oh, I'm bored or I'm turned off. You have got to stay vigilant in order to take care of you and your family.
Amen.
Very good. Before we close, the Black Health Trust is a 501c3. We invite you to go to our website, which is blackhealthtrust.org. There's a donate button. If you'd love to donate $500,000 or $1 million or 50 cents, we'd love for you to consider us as a worthy cause for you, so we can keep having these forums each and every week. We have interesting programs coming up. About what Dr. Walks said about personal choice. Dr. Walks, do people wear seatbelts because they like them, or will they get a ticket if they're driving without a seatbelt?
Dr. Maxey, my seatbelt messes up my nice jacket, but I wear my seatbelt for both those reasons, because I think it matters that I'm safe, and I think it matters that I'm a Black man in America. Do I want to get stopped by the police? No, I do not, Dr. Maxey.
Okay.
So I wear my seatbelt for more than one reason.
Do most people stop at a traffic light that says red, or a stop sign that's octagonal and says stop? Is that a personal choice?
It is not a personal choice, Dr. Maxey.
So I support your point that there are certain things that protect the safety of both ourselves and other people. And masking and vaccine taking are, in my mind, no different. We thank you for your time. I don't know if Ms. Ager is on.
She is.
Ms. Ager, we'd love to have your voice, followed by Pastor Pointer.
Okay, can y'all see me?
Yes.
Oh, I said, can y'all, you know I'm Southern, what can I say? It's been a wonderful morning. I stayed out late with my family last night, but I'm here just to say, amen. Keep on teaching now. Keep on teaching. Keep on teaching. Amen. 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 Oh, amen. God bless y'all, every one of y'all. Every one of
God
you.
bless you.
Thank you.